And to give you an idea of what was this. This is Lucio, who is 38. He's working in a bank, and he has this quite severe class 2 skeletal and dental with a large overjet, a very bad reconstruction and implant, and he has lost vertical dimension as well. That's very typical. I mean, a lot of prosthodontists see the patient in having lost the vertical dimension, and they don't think that this can be a result of the degeneration of their dentition. They say, oh, it's like this, and I will leave him like this. And this is really bad, really bad. And I have this experience with a lot of prosthodontists in Italy, and I can't understand why all of them work like this. So I make a repositioning. Lucio is able to stay in a more forward position. On this, we make the occlusogram. This was an old case, so I was not yet using Trigel. So this is a new position with the reduced overjet, as you see. So you see here the repositioning. You see here we have a full class 2 that has become half cusp. You cannot go more than this. In most of the cases, then we started work on the teeth. We had to open up a space on the right side. And we reduce in this way farther the overjet. Then I asked the prosthodontist to increase the vertical because I couldn't see him in that conditions. And we were going on with the orthodontic treatment. It was a very simple treatment because we didn't have to do very complicated things. It was just an idea of opening up the space and inclining a little bit to lower front and a little bit of alignment of the upper anterior. Here you see the lateral cephalometric at the beginning of the treatment. Here is repositioning. So just immediately after repositioning, and this is at the end of treatment or in the very last period. But no, it doesn't have the brackets, so I have removed. This is the condyle. After repositioning, and you see it's in the typical gel position. For class 2, they're all there because otherwise I'm not able to do anything. And this is Lucio at the end of treatment with the new occlusion. Still a little bit of material here. I know that he has to do still work with his prosthodontist. We have created space for the implant. And this is the nice part. So this is his new profile compared to the old one. We have increased the vertical. This is also important, but we have increased the vertical and advanced the chin. And this makes a difference. He is very happy not to have done surgery or other things. I think that for such a malocclusion, this is inappropriate. This is the condyle after the treatment is at least 2 years after the advancement, and we find a very stable position. This is the resume of the whole treatment. And this is Elena, the girl that I told you a little bit today, but I had to tell you more about repositioning. So today there was someone who was telling me, don't you believe the occlusal plane is important in treating class 2 or class 3? And I do believe that this is true, and I do believe that a rotation of the occlusal plane is also important to give more possibility to a forward advancement of the mandible, while a posterior rotation of the occlusal plane can help us in keeping the mandible back in class 3 cases. So to rotate the plane in this direction is okay. But as a general rule, also, we have to say that it's the reduction of the vertical height of this patient can be important in cases like this. If you see a patient like this, with this sort of bird profile, you always should think that she had a very severe juvenile arthritis. And otherwise, it's not very common that you have the development of this kind of profile. This patient, of course, was not aware of this and came for me because she had crowding of the lower front teeth. And she said, "Doctor, I need to fix this crowding." Of course, for me this was not really the problem. We have other problems. And, we have crossbite here, but actually the problem is that we have a large overjet. The problem is basically a skeletal problem. If you look at the dental relation, it appears to be a class 1. But actually this is a false class 1, because if you look at the inclination of the posterior of the lower teeth, you see they're very heavily tipped to the mesial. So there is a sort of dental compensation of the skeletal class 2, which leads you to almost to have a class 1 relation here. But the truth is that if you look at the canine, it's even more mesial, more forward than the lateral incisor. So this is really a false class 1 that is not helping us. So in my treatment plan, considering that we had the molar, that it was in very bad condition here, I have extracted this molar here, I have extracted, the molar to the right, and I have extracted the premolar to the left. And I have also extracted 2 premolars on the lower. Here you see in the lower that the second premolar has a mesial inclination. And for your joy, there's a snide eye. Is this a good thing for this mechanics? Thinking to this, I probably was not feeling very well that day that I placed this wire, because there could be some possibility of extrusion of this tooth that I wouldn't really have liked. I was lucky enough that occlusion here was good enough to prevent severe problems, but as you see, after a while I've just changed my mechanics. I was not very happy with this. In the upper arch, at this stage I had already made some intrusion of the most posterior teeth, that means the molars. And at this time, as you saw before, I'm intruding and retracting the premolars. So we are taking away this big step, and here you see that the occlusal plane in the upper arch is definitely more flat. And at this time, I repeat the advancement with the triagel. The triagel is here, if you don't see it. It's this part here. It's not empty, it's full with blue triagel. It's in different colors. I don't know why it's blue, but probably it was the first tube that it came into my hands. And I'm also working to finish the flattening of the lower occlusal plane. Now, the triagel is still there, and I'm using it to bring back the canine in class 1. Although this canine was moved to the distal, now the canine is more or less at the place of the first premolar, but now I'm bringing all the mandible forward. On both sides, you see the canine is here close to class 1. Due to the rotation, I could have done a little bit by intruding this teeth, but also very much by the work of the triagel, who's moving the condyle forward. Finishing the uprighting of the lower. Some minor movements, this premolar needed some lingual displacement. I still have some spaces here to be closed. In the final stages, considering I had tats, I was using them to finish space closure. You see a lot of triagel in these stages. Probably at a certain point I had a little bit of cant, so I moved the point of ligature to the left to correct this cant that appears to be there in the lower. And what is the mechanics I'm using now in the upper? This is a cantilever. We have seen this yesterday. This is both intruding and retracting, trying to give a force with this direction. Let's say don't have the tablet, so not very good. So finally, this is the case, and that you have seen this yesterday. And what happened? We had a rotation of the mandible like this, but also an advancement of the condyle in this direction. And that was also improved by the fact that we retracted both the upper and lower incisor. We have intruded the upper incisor, so she doesn't have any more to strain the lips. It's true also that she's keeping the lips apart here. And if she doesn't strain the lips, she can have a more normal profile of her chin. So this is the position of the teeth and the superimposition. And here you see the effect of the arthritis. This is her eminencia. And this is everything she has. When you see a patient like this, always give a look to the CBCT, and very often you find this kind of anatomy. So where should be this condyle be? In the middle of the fossa. There is no fossa. She never had a symptom. She never had a problem. There is some fossa, and I brought her in the gelt position, but here there is no reference. Anyway, she's okay with the TMJ, and after the treatment, she's basically in the same position, and that's her face. Actually, I had asked her before the treatment, look, you need to go to the surgeon. I mean, I'm not sure that I can do a good work for you, but anyway, that was not that bad, because we could improve a lot of things. For sure, with surgery, she could have been better than this, but she was very much afraid of doing surgery, as many of us are. This is a patient that was treated by Paola, and it's particular because it's a class 3, and it's not in the group that we have included for the study. Actually, in order to treat a class 3 in the CBCT, you need to see a condyle which is in the gelt position. Otherwise, you cannot think to. I wouldn't suggest to you to push the condyle back from a centered position to a posterior position. So a class 3, midline non-correspondence with the lower midline that is deviated to the left, class 3 on the right, class 1 on the left. And here you see that both condyle are rather forward. We were lucky because this patient is not in the gelt position. Gelt position could have been a little bit more forward, at least on the right side, not in the left side, yes. But there is space for bringing this to the distal. So she was lucky, we were lucky. And in the treatment plan, it was imagined that we could have had a retraction of the mandible. Actually, Paola started this treatment with some movement with the utility arch, trying to close the overbite, to close the open bite, and trying to bring the root forward. Personally, although this mechanical analysis is correct, I find it very, very difficult to apply a given force system with the utility arch, but nevertheless she tried to do this kind of activation, trying to bring the roots forward of this anterior teeth. Then, after some advancement, including the roots, she placed a TAD and started to move the anterior teeth, the posterior teeth a little bit more forward. We had to do a lot of displacement, but part of the displacement will be a rotation of the mandible, and part of it will be the movement of the canine. And here you see when, I don't know whether the triangle was put, I think not yet. Here was just the movement of the canine. And I think that at a certain point here, but as I said, this is not my case, she started to use the tri-gel. She was also helped by this elastic. I'm not using elastic very much, and if I'm using them, I'm using more with this direction rather than this one, in order just to help the interdispersion. Here we have the mandible, which is now corrected. And so this is at the end of treatment. And definitely, you can't imagine that we can correct this position just by moving teeth to the distal. And actually, we didn't move the teeth to the distal. She didn't move the teeth to the distal very much. Just I don't think this elastic can do a lot. This is the case at the end of treatment. She was